Okay. Uh, Good evening, everyone. I, Dr. Shatakshi Rai, on behalf of Glenmark Pharmaceuticals, welcome to an advanced training program in collaboration with the Association of Physicians of India. It is my privilege to welcome everyone to this fifth webinar of our advanced training program in 2D echocardiography. This program is thoughtfully curated for clinicians who seek to deepen their expertise in cardiac imaging and elevate patient care through precision diagnostics and interactive case-based discussion for collaborative learning. Today's webinar focuses on a case-based discussion based on echo in clinical care patients, where we are honored to be joined by a distinguished panel of experts whose contributions have shaped echocardiographic practice nationally and globally. Today with us, we have today with us we have Dr. Nitin Burkule, our moderator. He is pioneer in cardiac imaging and a recipient of Lifetime Achievement Award from Indian Academy of Echocardiography. Currently, he is a director in Department of Cardiology at Jupiter Hospital, Thane. He also has various affiliations and is a co-author of ASE guidelines of ASD and PFO evaluation, IAE guidelines of ASD, IAE guidelines of stress echocardiography in CAD, comprehensive adult TTE and TEE, and TEE in cardiometabolic strokes. I would also like to welcome our eminent speakers for today's discussion. Dr. S.K. Parashar, Senior Consultant at Metro Hospital in Heart Health Institute. he, he has numerous fellowship and is member of various medical and cardiology association. He has also received prestigious awards along with Lifetime Achievement Award from Indian Academy of Echocardiography and Indian Medical Association, and also from World Federation of Clinical and Preventive Cardiology. Dr. Rakesh Gupta, sorry, Dr. Rakesh Gupta, Senior Consultant Cardiologist at Max Super Speciality Hospital, New Delhi, and Director and Chief Cardiologist of Echo and Color Doppler Center. He has also received numerous awards, along with Lifetime Achievement Award in field of clinical and preventive cardiology by President of India in the year 2007. Dr. Satish Govind, Chief of Non-Invasive Cardiology and Secretary of Medical Ethics Committee, Narayana Institute of Cardiac Sciences, NH Health City, Bangalore. He has over 35 years of experience. He is also honored with award of outstanding contribution to cardiology from AAPIO in USA. He has also multiple publications in various national and international journals. Dr. S. Shanmuga Sundaram, Senior Cardiologist and Interventional Cardiologist at Bilruth Hospitals, Chennai. He is a member of Indian Medical Association and Tamil Nadu Medical Council. He has 43 years of experience in invasive and clinical cardiology. He has also presented and published various research papers in national and international journals. With this, I would like to present today's agenda and welcome the agenda. So we will post this. We'll be having a first case discussion where two cases will be presented by each of the speaker, and the time limit is of about 20 minutes with 15 minutes of presentation, and we can have 5 minutes of discussion. Post that, we'll be having vote of thanks and closing remarks from our Glenmark team. With this, I would like to hand over the session to our moderator, Dr. Nitin Burkule, sir. So please, we may start the session. Yes, sir.
Thank you, Dr. Shatakshi. Thanks for introducing all the speakers. So that makes my job easy. And let me, at the outset, give thanks to Glenmark and API. Their joint efforts has made this session possible. And interestingly, all the faculty, right from the first session and up till now, is all from Indian Academy of Echocardiography. So almost it is like a joint event of IAE, API, and Glenmark. what we will do is we are today going to showcase the use of echocardiography in critical care by doing the point of care or bedside echo. And let me tell you, that is the greatest strength of echocardiography, which is not rivaled by any other imaging modality. Okay, the way the echo can go to the bedside, it is so versatile, so portable, and the rich investigational insight it gives into that particular case to take rapid decisions to save the patient's life is almost unparalleled. So to showcase all these cases, we have got four eminent speakers. All of them are past presidents of Indian Academy of Echocardiography, and they have done a great contribution both to Indian Academy of Echo and also to the field of echocardiography. So it's my pleasure to and honor to invite Dr. S.K. Parashar sir. He is the founding president of Indian Academy of Echocardiography, and he would be presenting the first two cases. So what we will do is we'll finish the cases in around 15 to 20-minute bracket, and we'll take as many questions as possible. And after every speaker, we'll have question and answers, and we'll go to the next speakers. Dr. Parashar sir.
Okay, can I let me is my is the mic visible?
No, sir.
Uh,
We are still getting your only video.
No, no. Is my slide presentation there?
No, no.
अच्छा, तो I'll again
Yeah,
I'm share screening again.
yeah. Yes, it
Yes, sir. Now we can see, sir.
No, I'm not able to see my presentation yet.
yeah, this we can see that. Yeah, it's there. Correct.
Now,
Yeah, we can see it.
now is it all right?
Yes, it is.
Yes, sir.
You can go ahead.
Oh, okay. Because of some lack of communication, there might be some problem in the presentation. Because I'll have some 3, 4 short cases or so, and I thought it is the first presentation, so I brought some extra slides, which may not be needed because they are physicians. So I thought that they'll be needing some of these. As mentioned earlier, why echo is designated as a miracle? It is the heart of clinical cardiology, plays a spectacular life-saving role like never before, and the key components are establishing the diagnosis, prognosis, critical to management options, and as mentioned by Dr. Nitin, its strength is portability in any area of the hospital, giving immediate diagnosis in emergency situations. Please note that gives immediate diagnosis in emergency situations. And as we know, I think most of you now know what is a 2D echo and a Doppler because I did not know that this is I thought it is the first session. The 2D echo, as you know, a large number of structures are seen simultaneously, gives an anatomical information, how are the chambers, how much are they thickened and what not, and all full functional information. Because in any critical care unit, we always like to give an impression of a functional information. Now, this is like a representative slide of one of the views where you can see simultaneously a lot of structures, aortic cusp, aorta, LA, mitral wall, RV, LV, all of them can be seen. Now, here if you see the aortic cusps are opening very nicely, they are thin and no problem. But if you see here, the same thing is seen, it's a very markedly calcified thickened walls. So this indicates that the patient has got a severe aortic stenosis, and this should be supported by the other tests which we do. So these are one of the some of the uh, again you see here this is LA. Sometimes when you don't expect it, you get a tumor into the left atrium like a left atrial myxoma. The patient may come with a variable complaint also, but suddenly you find it also. So these are just few 2D. So you can see multiple clots also present in the heart. So these are some of the important 2D findings which you can see in the various images that you can see. Now, in a Doppler, we get a hemodynamic information, and Doppler is a very important aspect. I think because it has been discussed before, so I will go across it. Now, coming to the critical care echo, what is a critical care echo? It is the use of echo in the assessment of patients with unstable cardiovascular state and is a diagnostic echo study. Hence, this is important. It is a focused and a goal-oriented limited examination for immediate actionable information. Remember, this is the most important sentence for immediate actionable information which can be given at that time. Now, sometimes the problem is this that good skill and experience is required because the need is for rapid echo. Thereby, some problems occur in the critical care unit. The patients are in various postures, often heavily sedated, multiple IV drips, often intubated, on ventilator, intrathoracic surgery, chest trauma. So both of these things are very limiting in the examination because the patient cannot be shifted in any other position also. So that is why a good experience is required. In one study, it was noted that the management are changed in about 51% of patients when the echo was used in critical care units, and this included modification of fluid administration, inotropic, and drug therapy. So that was the importance of an echo here. So that means once we repeat that it is critical in diagnosis and guiding therapy, now you see it can be done anywhere. Intensive care can include a coronary care, emergency, post-operative, medical ICU. So anywhere the echo can be done. And because of its information about diagnosis, prognosis, hemodynamic assessment, it is invaluable in ensuring optimal patient management. All the three are equally important, but the 2D echo and hemodynamic is more important. And that is why you see the echoes have been so much matured. This was the usual machine, and now we can get handheld machine which can be put in a pocket and be taken to any unit. So there are various types of these machines. So these are the diagnostic dilemmas we normally we feel in emergency care unit. But the most important is hypotension, breathlessness, and chest pain. These are three. Other ones are relatively uncommon, but these three are the most commonly seen, and they are some listed as some of the causes which possibly the others will also see. So this is the three important features. Now, a shock is a life-threatening condition in which there is a persistent hypotension, systolic BP more than 90 in presence of adequate intravascular volume. And this thing you can yourself determine a shock index. As a physician, you can determine this is nothing else but a heart rate divided by the systolic blood pressure. Whenever there is a hypotension or shock, there is a tachycardia and the BP comes down. So when the heart rate is increased and the systolic BP is less, the shock index increases. And this is the normal zero point 0.5 to 0.65. This you can determine in your own self in any patient you see with hypotension. And again, it was seen that in 54% of cases, the recent study, the echo was very helpful in various types of shock. Now, hypotension, I told you, is one of the important aspects. The most common ones are hypovolemia. One should not forget sepsis, marked reduction in cardiac output due to extensive infarction, and various mechanical complications. So, echo can easily see most of these causes can be found out because these are some of the common ones which will show you. Now, this was a 46-year-old gentleman, came with a BP of about 96 millimeter mercury, no other associated features, looked a bit dehydrated, sinus tachycardia. As a part of a hypotension, what we found that there was a markedly small IBC. In every ICU or critical care unit, we always report the IBC because normally the size of the IBC and here you see it is markedly reduced, and this indicates the presence of a hypovolemia. Why evaluate IBC in every case? It is synonymous with central venous pressure. It gives an idea of intravascular volume status, a critical in therapeutic decisions. If the IBC is dilated or responds poorly to inspiration, we have to restrict fluid. But otherwise, we had to give fluid, and that is why in this patient, because of a markedly collapsed vein, we gave a fluid so that in every critical care unit, we always see for size of the IVCL response to inspiration, and we report it in the day-to-day functioning in that. Now, fluid therapy, I'm not going into detail because this is in itself it should be right patient, right fluid, right volume, right time. In a cardiogenic shock, it can be 100 to 100 to 50 ml and assessed after each bolus, and hypovolemia 20 ml per kilogram. Now, at your level, not going into IBC, what you can do as a physician, you can find out whether the patient is responding or not. Raise the patient's leg if the BP is increasing by more than 10%, that the patient is responding to the treatment. Again, you see the shock index. If the shock index gradually goes, because these others are mainly echo based, if the shock index is gradually reducing, that means the patient is responding, his heart rate is getting low, and the BP is increasing. So these are two things you can easily see. And those who are interested in echo, they must see IVC, and this also we add the various clinical parameters. Now, this was a 62-year-old gentleman who suffered an extensive anterior wall MI, was admitted to ICU, thrombolized and stabilized. On day 3, he suddenly deteriorates and goes into pulmonary edema and hypotension. You see, he has got a marked tachycardia, BP is markedly reduced, and a soft systolic murmur is heard. This is just a representative slide. Again, in normal slide, you can see the normally contracting LV and IBS is normally contracting. But in this patient, when we did a bedside echo, you see there is a rupture of the IBS, and the fluid and the flow can be seen from left to right. You see the LVs enlarged, and you see there is a rupture, and this led to a marked a shock and pulmonary edema, and you see the heart rate is about 140 per minute. So always look for these situations when you see a systolic murmur. So because it is a very high in the hospital mortality, it is easy to say about the management. You have to stabilize the patient with fluids, sort of a vasodilators. But the problem is surgery and percutaneous closures are two options. But because the margins are very fragile, the surgery may be dangerous, and the same thing here. So that is why the high in hospital mortality, because these things are delayed. So that whenever she has systolic murmur with a marked hypertension, you must see this also. A 27-year-old lady, restless due to shortness of breath, could not lie flat, tachycardia, febrile, blood pressure low, and clinically no significant murmur. So the main thing was the presence of a hypotension and a shortness of breath. Now this is a normal apical four-chamber view. You see this normal contractility of the heart, all the four chambers. But in this patient, you can see like the heart was swinging like a pendulum, as it was free in the pericardial fluid, and it was moving like a pendulum or a dancing in the heart. That was a very classical sign of a cardiac tamponade. So remember, a cardiac tamponade as a physician always suspect when there is a presence of dyspnea, tachycardia, hypotension, distended neck veins, and pulsus paradoxus. Distended neck veins is because of the pericardial fluid compressing on the heart. So these are some of the signs which should always be seen, because it is the mortality is very high, and the patient has to be the fluid has to be immediately removed also, so that these things gradually disappear. And as soon as you remove some of the fluids, the patient actually will start smiling because it's so good. So in these, especially dyspnea, hypotension, neck veins, always consider cardiac tamponade, and these are all real life cases done in the ICU or at the bedside. So then acute chest pain is very important thing, which is a major life-threatening emergency in every ward. As I told you, hypotension, dyspnea, chest pain. So acute, we always want to know whether there is an acute coronary syndrome or not, and if there are any complications of the acute coronary syndrome leading to hypotension. Then, beside this, the two life-threatening are aortic dissection and pulmonary embolism. So this was a 41-year-old hypertensive male on irregular treatment, complained of severe pain chest, radiating to left arm. Patient was restless, dyspneic, tachycardiac, and hypertensive. All the things are present. And here you see again the representative normal slide. You see the aorta. You see the aorta is very clear. And only the aortic wall is seen and nothing is seen in the aorta. But in this patient, you can see there was a sort of a membrane here. This is known as the intimal flap. And this you see the aorta is dilated and in a transthoracic echo, we could see this. And this gave us a diagnosis of an aortic dissection. And you remember that again, what is the aortic dissection is, there is a rupture of the intima. There is a rupture of the intima and the flow goes through this rupture into the media and this intima produces what is the intimal flap and this is the thing. And as a physician, when should you suspect aortic dissection? Chest pain that is migratory and radiating to back, chest pain with severe abdominal or back pain, chest pain with neurological symptoms, chest pain with signs of vascular compromise, chest pains with murmur of air, and chest pain with variable arterial pulsation. That is why a teaching has been that whenever you get a patient of a chest pain, always palpate both the wrists. You see palpate both the arteries and rather than one only, and sometimes you may be benefited when there is a variability in this. So these 7 things are important for you as a physician before you discuss this. Now we have a last case. This was a very short contact with patient. This was a 27-year-old young man of a Russian descent. In 2009, he had an amputation above knee for chondrosarcoma and a shortness of breath off and on. Now his oncology clinic of the large hospital was close to our hospital, so that all the malignant patients were or the patients were sent to the hospital which was nearby near us. So this oncology clinic found that the patient is not looking well, so they immediately sent to us in our hospital. Immediately we did a bedside echo. Actually, the patient was almost on a trolley. He looked very sick. He was dyspneic, tachycardia, hypotensive, and oxygen saturation was low. So all these things were very, very suggestive that the patient had a very severe problem, which can be either a tamponade or an a sort of a pulmonary embolism, anything. So when we did an echo, now this is the pulmonary artery, and this is the aorta, this is the aorta. You find that there is a bifurcation of the pulmonary artery. There is a huge big clot extending into the right branch of the pulmonary artery. And this is seen as a static image. Again, pulmonary artery you see, and before the bifurcation, the clot here, and this thing was there. So, because he was with us, we gave an emergency treatment, a controlled fluid, but not an aggressive fluid. Otherwise, this aggressive fluid intake will further harm the right ventricle. Oxygen, we gave a TPA. There was hardly an improvement. Despite all the features, was hardly an improvement. So we transferred to the parent hospital. And as a clinical interest, we just wanted to see. And there they did a CT and they found an acute saddle thromboembolism. They also gave all sorts of a treatment, but the patient never responded. Despite all measurement, the patient had a very unstable hemodynamics. As such, when in these situations, a surgical embolectomy was done, and the why patient did not respond because the biopsy showed a metastatic emboli of the sarcoma. So that is why it was not a usual thrombus, but they were metastatic emboli of the sarcoma of the old malignancy, and that is why the patient did not respond. So this pulmonary embolism can be clinical dilemma, non-specific, can be silent, absence of a triad, that is the rapid onset of dyspnea, tachycardia, pleuritic chest pain, hemoptysis may not be present, and sometimes the risk factors may be present much before, and there may be no provoking factors in 25 to 30% of cases. So one has to keep this diagnosis in mind when you get a hypotension also. And the management stabilities are they stabilize the patient. Anticoagulant is the first line of treatment with thrombolytics and other things also. And nowadays, what we prefer is to give a TPA And what we gave was also it is 100 milligram because of a very rapid action also. Sometimes the problem because of how long to give, it is all variable. Where patient with a reversible risk factor about 3 months, unprovoked pulmonary embolism with low risk of bleeding 3 to 6 months, patients with irreversible risk factors, possibly a long term or lifetime may be given if there are no associated causes seen. So that in summary, Econ play life-saving role in critical care units and guide management. It's in one study saved the life of vital clues in diagnosis, and one must be very quick in evaluation. Main thing is that give a structural hemodynamic information and give an answer why patient is deteriorating so that you have to do a rapid but a full examination, and all staff managing critically patients needs some skill in echo. So this is implemented there. Now this is because it will take some time, so we'll not show you the technological advances also. It may take about a minute how the echo has been, how the echo has progressed over a time, Doppler, hemodynamics, transesophageal echo, intraoperative, contrast echo, color flow mapping, IVA. So these are all some of the branches where the echo has very progressively increased, and they have given us the various other important things. And so finally, this is an important eco algorithm. Whenever we get a patient who is unstable patient with shock or pulmonary edema, we do a quick targeted echo, minimum views, and normally here we get apical and the subcostal view. So if the patient is unstable, you find that there is a pericardial effusion, assume tamponade. When you find severely enlarged and hypokinetic RV, assume pulmonary embolism. And when there is a severe hypokinetic LV, assume a pump failure or the mechanical complications. And when there is a hyperdynamic, small hyperdynamic collapse IVC, severe hypovolemia, or a sepsis or so. So these four eco algorithms will give you some idea as to what is the cause of this patient's unstableness. Thank you very much.
Uh, Thank you, Dr. Parashar, sir, for the all the four cases, and I think all the four cases were exemplary to show that the patient who was fighting for the life, we have got the reason or the etiology of the patient's instability by just doing a bedside echo. So I think we will start with the question and answers, and Dr. Parashar sir will also answer, and the other faculty also, if they want to make a point, can always add to it, so that we will have a very good discussion. So I think the first thing was, I think in your case, first thing that you showed that echo is very valuable for the preload determination. So, sir, can you
Yeah.
quickly elaborate on the IVC size and the respiratory variation? You had shown
Say
the IVC size, just to get an
the
idea about
normal size
objectivity.
the
Yeah.
normal size is about, can you hear me? Because I
Yes, yes, we can hear you.
the normal size is about 20 millimeters or so, average about, but depending on body surface weight. And during inspiration, what happens that there is a fall in the intrathoracic pressure during inspiration. So then the intrathoracic pressure falls, the RA pressure falls. And when the RA pressure falls, the blood from the IBC suddenly comes into the RA and it shows that inspiratory collapse. So that means normally it should be less than 20 millimeters or 21 millimeters and should show more than 50% collapse. As the IBRA pressure increases, automatically and as the RA pressure increases, the size of the RA increases, the IBC and its contractility decreases to less than 50% or so.
Okay. Second is that to visualize the IVC, which is the best view, because I have seen that most of the
Anything,
cardiologists
I
look at
think,
the IVC, and most of the radiologists they look from the
pardon,
uh,
the best the
the
best
best
view
view for the IVC, because what happens is I have seen
the
them.
best view for the IBC is the subcostal view. That is why whenever you go to the That is why when you go to the subcostal view, it is always better to try to always have a subcostal view, because sometimes the patient cannot change to one side also. Subcostal view is the best view to see for the IVC.
Okay.
And during normal respiration, some persons are the patient or in normal respiration, you can subcostal view.
Yeah. So the way, so one of your slides said that the IVC is just like JVP. It just reflects the waveforms of jugular venous pressure. So is there a way that echo can also have a look
Yeah.
at the SVC? Yeah, can you hear
Yeah,
me?
yes. SVC can be looked both from the subcostal view and from a suprasternal view. So
Okay.
SVC can also be seen. And that is very well said, can also be studied in that case. And when we do a IVC, we also see the hepatic vein. So SVC can be seen in these views also.
Yes. Then one of your case had a pericardial effusion and patient was in hypotension and in tamponade. Now the question is like this: ki we see a lot of patients with pericardial effusion, but many of them may not be in hemodynamic tamponade. So how the echo differentiates between the pericardial effusion with tamponade versus pericardial effusion without tamponade?
Sometimes even a large pericardial effusion can manage like a tamponade. What happens in tamponade? There is the heart is being surrounded by the fluid, which compresses the heart. When it compresses the heart, so there is a change in different pressures also. So two signs which is being shown in a pericardial tamponade is a right atrial collapse and the RV collapse also. And beside that, there are there are two things on they should remember is what is known as a sort of a exaggerated descent also, in which the IVC beside the parasternal long see the exaggerated interval collapse also. There are two things are the pattern of motion of the heart and the signs of various IBC. There's a RA collapse, late diastolic collapse, and early collapse of the right ventricle. These are some of the two signs in which RA collapse is more important than IVC.
Yeah, yeah. That is the way because some of their pericardial effusions may have accumulated very slowly, and they still not be having a tamponade. But some of them will definitely have a tamponade, which you can make out very easily looking at the RARV collapse, as Dr. Parashar sir had said. Then I think another very important part of his presentation was the patient with chest pain and hemodynamic collapse, and we looked at the dissections. Now, most of the chest pains are most of the time the concept is any chest pain coming is a coronary, and many of these patients get a loading dose of antiplatelets, and then you find a dissection. And actually, as we know that obviously the loading dose of antiplatelet is contraindicated in presence of a dissection. So I think it is one should liberally use the echo bedside in acute chest pain situation. And I think that point was very well highlighted in his case, where the patient presenting with chest pain actually had a dissection and no regional wall motion abnormality. So I think in the interest of time, we'll go for the next presentation. And next presentation is by Dr. Rakesh Gupta. He will be showing you the cases where the bedside echo has helped the patient. Dr. Rakesh Gupta.
First of all, thank you very much, Nitin, for giving me the opportunity to talk on this platform. And thank you, Landmark and API. Two important things which happens in emergency all the time. One is an acute chest pain and second is a heart failure. And these are the things which are happening every day in day-to-day practice. So let me start with this first presentation of mine. What is a patient is 53-year-old lady, presented with chest pain for 3 to 4 days, associated with marked weakness. Pain was classically heaviness in the chest, which increases with walking. Blood pressure was normal, pulse was normal. There was evidence of a systolic murmur in mitral area. If you look at an ECG, ECG is certainly a non-diagnostic. We could not find anything in this particular patient when it was done on the first day at the time of presentation after 3 to 4 weeks. Surprisingly, the TROP-I test, highly specific troponin I, when we did it, the observed value was 0.11 when the troponin is less than 0.05 nanogram per ml, which is negative. But it has to be more than 10 times to be positive to call it as clear-cut positivity. So here's a chart which talks about 99th percentile, and the value was somewhere in between 0.11 nanogram per ml. We were not really sure whether we are dealing with this particular abnormality or not. So hence we went on further and we did an echo for this patient. We can see the images of this patient over here, right? We couldn't find any significant wall thickening abnormalities, except for the fact basal inferior wall was relatively hypokinetic. Rest everything was very much normal. Surprisingly, when we did a color Doppler for this patient, we were able to get a significant mitral regurgitation. It's not more, at least mild to moderate. Now, next things which come up in this particular patient was, it was very good imaging quality. We went on to do a two-dimension stain for this patient. I know like this is one modality which could be a little advanced for the basic students, but this is what is helpful as on today in today's practice. Surprisingly, when we looked at this two-chamber view with basal inferior wall, it showed post-systolic thickening in particular segment of the basal inferior wall. Similarly, if we looked at this basal septum of the same patient, even this showed something like a post-systolic thickening, whereas rest of the segments were reasonably normal. Now the question is, what are we dealing with? Strain imaging guidelines just published in JACE 2025 said if you have a significant post-systolic thickening, it suggests infarcted segment. And that was more important. And now the question was, when we had a borderline enzymes levels, we had no significant wall motion abnormalities. On top of that, we had a post-systolic thickening with strain imaging. What to do with this patient? That was the most important thing. This is another slide from the same strain imaging guidelines. Now the question is, what is the history? History was so specific, like if you look at the history was very specific. She has got a heaviness chest, which increases with walking. Second important thing was she had a borderline highly positive TROP-I levels. No significant ST wave changes. Subtle may be possible, but this is what was most striking was abnormal strain rate, especially the post-systolic thickening by advanced echo. We looked at the slide, and this is one of the criteria for rule in and rule out for acute coronary syndrome emergency, where they would do a troponin I at every 1 hour. And if there's more than 10% rise in troponin levels, obviously it becomes significantly positive. Our patient has presented with 3 to 4 days of chest pain, and we had a borderline emergency. We were not really sure what to do with this subject, whether we should rule out or whether we should rule in for coronary angiogram. Then we looked at the history. History was so specific, like heaviness chest, tightness, exertional stress related. And this graph was published in 2022. They said the classical history is so specific that it belongs to probability of ischemia. We went on to do echo imaging again. We looked at the basal inferior wall was appeared to be hypokinetic. And finally, we had the question whether we should send the patient home. What should we do? And we decided for a rule-in of this particular patient, looking at the history and everything. We went on to do an angiogram for this patient. This is left heart shot. And look, this is the right heart shot of the same patient at the same time in the evening. And we could see a significant tight lesion in the mid RCA level. Obviously, when we saw this lesion, which was very well coordinating with our echo findings, coordinating with our suspected echo findings and other things, and we did an angioplasty for the same subject, and patient was significantly better after that. Now, in chest pain evaluation, what is the most important thing which is happening in us today? Medical history, focused physical examination, Immediate tests like ECG and a tropi, and as Dr. Parashar sir has said, like these things help in ruling out heart attack, pulmonary embolism, aortic dissection. And CT scan, echo with strain imaging is one of the modality which helps us in coming to a conclusion. Thou echo is not in a cardiac trials as on today, but it plays a significant role in enhancing the diagnosis. That what has been said in this JACE 2025 strain limiting guidelines. So, however, in our patient who do not qualify to rule out or rule in, a third measurement of cardiac troponin I at 3 hours or echocardiography may be required. This is what is, if you have a patient with a cardiac abnormality, suspected coronary artery syndrome, do a third time of a troponin level and use echocardiography. While the third measurement is mandatory in cases of recurrent chest pain or a high-risk patient, such as an angiogram, which was shown in that patient. So that is my first presentation of use of echo along with tropi and along with the advanced modality of strain rate imaging in day-to-day practice. Let me move on to my next presentation. My next presentation goes to a breathlessness. And very surprisingly, this is one of the patients we saw in emergency. This is a 104-year-old lady which presented with a casualty at the midnight hours. She was breathless off and on. This happens at home, which is approximately 20 kilometers away from a hospital. And by the time she is transported to the hospital, she is normal. And it has happened for the 7th time she has come to the hospital. When we looked at her, her pulse was 100, BP was 110/70, JVP was not raised, HGR was not positive, temperature was normal, nothing significant as well other things were, but she had bilateral basal cuts and bronchitis. No pedal edema, liver was just one finger breath palpable. Normal sinus rhythm, no significant ST wave changes, no sinus tachycardia. And we looked at an ABG of the same patient at particular time was normal. And amongst all these things, only one thing which was little striking for this lady was presence of a BNP at this level. This is all happening in the emergency level at our hospital. We look at an X-ray chest of this patient. Looks little like multiple reticulonodular shadows were seen in the heart. And now look at the echo of this patient. And look at the timing. Timing is 11:53.23 p.m. in the midnight. We were in emergency and doing the echo. Look, IVC is collapsed. Certainly, she is volume deficit. This is so-called a plaque tube, which showed evidence of aortic regurg, at least moderate or mild aortic regurgitation. The next important thing, she has significant annular calcification. She has got thickened aortic valve leaflet, almost normal contracting LV. She has mild to moderate mitral regurgitation as well. And another picture of the same thing, and here is the Doppler flow pattern of the same subject. Now the question is, what are we dealing with? Why she's having a recurrent breathlessness? Why she's coming to the hospital? Is it respiratory, cardiac, metabolic, or we do not know about it? Only thing we know from our literature, the causes of breathlessness, which improves the change of position, is possibly myxomas or pleural effusion, which helps. But when we are doing echo, certain things which we observed over there. Things were, look at the timing, 11:53, 11:54. And as soon as the patient went on, somebody is talking in between. May I request somebody to stop talking in between? It's creating a disturbance. Now look at the timing of this echo. If we were doing an echocardiography, this is around about 12 o'clock in the midnight with a heart rate of 108 beats per minute. And suddenly this patient started becoming breathless. And when the patient started becoming breathless, and now look at the timing of 12:03:15, this patient has heart rate has changed to 115 beats per minute. And now at 12:01, this is the previous one, and the heart rate is back to normal in 1 minute time. This is the Doppler flow pattern when she was having an abnormal heart rate. It means to say that possibly she has gone into atrial fibrillation at that particular time. And 12:06, look, she is back again to normal sinus rhythm at the midnight. Answer is, this patient or this Nani was breathlessness. She was not faking or she was not feeling anything about her breathlessness. This is what the Doppler flow pattern at the time when she was breathlessness. This is a Doppler flow pattern which was normal a few minutes back. Look at this 1203, 1202, 1203. And this is a classical case of recurrent atrial fibrillation producing raised LVTP breathlessness not previously identified because it was presenting off and on. To summarize, saying that it's a non-valvular, common in older subject, presenting with intermittent phenomena. Prior to AF, majority of these people have heart failure with preserved ejection fraction. I was looking at the literature, how many people they have this atrial fibrillation, which is non-valvular. Almost 3 to 4% of person per thousand people per year population is, and it's increasing significantly over a period of time, especially for a men. And another paper published from our own country saying that 165 patients, out of that, majority were 50 to 65 years age, that is 45%. Atrial fibrillation was common in men. And this is a very, systemic hypertension is a very common etiological factors. Another paper suggested that prevalence of heart failure in atrial fibrillation. The FM study, Realize AF pilot study, and a race to says that these are the people who develop atrial fibrillation over a period of time. My question is, if you have a patient of atrial fibrillation, heart failure with preservation fraction, they have a very high chances of getting into atrial fibrillations. Prediction of AF in heart failure with preserved ejection fraction, and this has been very well catered by this JACC cardiovascular imaging in 2022. One, an algorithm tells you which of these patients are going to get into atrial fibrillations over a period of time by looking at LSA. I'm sure like a little bit over for a normal population. But if you have a patient of heart failure with preserved ejection fraction, please ask them to do a left atrial strain, and that will tell them, look, if my peak atrial contraction strain is reduced, almost 30% of these people have the chances of atrial fibrillations. My take-home message from this particular case is atrial fibrillation is significantly common in elderly hypertensive population with high mortality and morbidity. Elderly subject initially present with heart failure, preservation fraction, and subsequently convert to AF. Prevention is more important to identify than treat. Thank you very much for your patience here.
Uh, Yeah, thank you, Dr. Rakesh Gupta, for those two cases. And both of these two cases are actually our almost a day-to-day, presentations of our patient. The first one is obviously the chest pain, and in Dr. Parashas's case, it was a dissection, and in your case, it was an acute coronary syndrome. So now you use the post-systolic shortening or the strain imaging for diagnosing that subtle myocardial dysfunction, which was because of an ACS. Now, many of our physicians may not be very well versed with the strain concept. So, can you just elaborate in a very simple term what exactly the myocardial strain is and how do we measure it on the echo?
It's a very simple method. Like we look at an echocardiogram, then we acquire an quality like 4-chamber, 3-chamber, and 2-chamber views, and let this sonomicrometer decide how much that particular segment has moved over a period of time. And this is very simple. I know like this is not for initially basic, but this is how it has become very useful in, and it is not useful in every subject, to tell you very honestly. This is only useful when you are suspecting acute coronary syndrome, you are not able to get a good answers. So just do a strain imaging for that particular segment. As I showed earlier, if it showed evidence of a post-systolic thickening, post-systolic means after closure of aortic valve, if you still the segment is contracting, that is possibly ischemic. And as I said, showed you earlier, other segment except for basal septum, basal inferior, they were all contracting at the same time at the closure of aortic.
Yeah, correct. And I think I would say the physicians, you should not get bogged down by the concept of strain. The if you take a very good 4-chamber, 2-chamber, and long axis views, the most of the strain measurements are semi-quantitative. So you have to just look at the quality control of your images. Otherwise, the rest of the things the machine does it, and it really gives you a lot of a very rich information about the myocardial mechanics. Now, my second question to you, Dr. Rakesh, is that now this patient also had an troponin which was raised above the 95th percentile. Now, suppose this patient had the classical chest pain, but the troponin level was normal. Okay, and suppose the the strain parameters were not very conclusive. would you add stress to your echo examination?
Certainly, what I like to do is at least watch for 3 hours duration every time getting a troponin I levels. If they show a starting rising behavior, I'll not prefer to do a stress echocardiography. If they do not show a rising behavior, what we do in our hospital is we treat them as acute coronary syndrome, load them with the medicine, and call them back after 24 hours or 48 hours for stress echocardiography.
Yes. So I think for the as we know that the stress echo is a very versatile stress imaging technique, very cheap, very versatile. You get very quick results also, and it is much cheaper than the stress MR or the stress thallium. So can you a little elaborate on this stress echo? How do we exactly do, and what exactly we look for in our stress echocardiography?
It's very simple. The most important thing is the setup of a stress echocardiography. The table, as well as the machine and a treadmill, they should be in the same room on a walkable distance of a few seconds. That's one. Second is we acquire a quad screen imaging technology where we acquire 4 chamber, 3 chamber, and 2 chamber. Put the patient on a stress test. If the patient becomes symptomatic or achieve more than 85% of a target heart rate or 9 minutes of exercise, we stop at that particular moment, switch him over back to a table, and acquire the images in less than 1 minute at every cost. Because acquisition of images is most important, and what we utilize in our setup is continuous capture technology. And we have put up a system in our lab, like we every 1 minute the ECG machine will tell you your 1 minute is over. So your target is less than 30 minutes seconds of acquisition, 5 to 10 seconds of movement of patient. And now once we do acquire these images, we look for segment to segment in 4 chamber, 2 chamber, or 3 chamber. Suppose in 4 chamber is we look at the basal septum to basal septum, basal inferior to basal inferior. And that is the most important thing of a quad screen technology, where we look at the segment to segment levels. On the other hand, ECG is also going on simultaneously. That helps you in coming to a conclusion, look whether some changes are happening or not, especially when the patient is stressing on a treadmill. And our personal uh, context is, our personal thought is, when the patient start talking of a heaviness just during walking, believe my word, that's the most important significant sign. No chest pain to begin with, and the chest pain or heaviness, not the chest pain, heaviness start appearing either in the chest, left shoulder, or jaw, or back. And that is the most important thing, that patient is starting having a symptomatology of coronary artery disease.
Yeah, excellent. I think we are very much underutilizing this very important modality. And as everyone knows, physicians, that the stress ECG has got a lot of false positives and false negatives. And when you add the stress imaging, you don't have to do any more investment. You already have a treadmill and you already have an echo machine. Only you have to bring it in the vicinity, and you can improve your sensitivity and specificity beyond 85% by doing a simple stress echocardiography. And the last question to you, Dr. Rakesh, was about the atrial fibrillation that you had shown, which was making the patient symptomatic intermittently. And as we know that paroxysmal atrial fibrillation is the thing where the patient has to be lucky to have an atrial fibrillation in front of the clinician. Otherwise, poor people directly come with a big stroke, isn't it? So I think as a echo examination, we can predict the patients who are having a left atrial dysfunction. So can you elaborate a little bit on the left atrial imaging? Because I think everyone is fixed to the left ventricle and we are neglecting the left atrium. And as we know that the left atrium is such an important source for everything, right from the mechanism of HFpEF to the mechanism of cardioembolic stroke. So can you just elaborate a little bit on the how to evaluate the left atrium?
Correct. Very simple way is, if your patient is having intermittent atrial fibrillation, in 4 chamber view, both your left atrium and right atrium, they look almost same size. In normal circumstances, they are not. Second is, look at the LA size in AP dimensions. If it's more than 22 millimeters per meter body surface area, your ear should start ringing. Look at your LA volumes. If they're more than 34 ml per meter body surface area, your ear should start ringing. And on top of that, look at E to E prime ratio average. If it's more than 10, look, your LA pressures have gone up high. And these things are very simply available in virtually every machine. And today, if you are good enough to do echocardiography, it's a very simple quantitative estimation of LA strain. You just have to acquire LAs in 4 chamber and 2 chamber and do a good LA strain values. And that gives you very good idea of LA atrial myopathy.
Yeah, excellent. I think that was a very important point that we have brought up, that now we have to look at the left atrium in every echocardiography so that we don't miss the HEPs and the patients with a potential risk of PAF and cardioembolic stroke. Thank you, Dr. Rakesh.
One sentence I'll say before I close. We just published a paper in Indian Heart Journal. We looked at 330 cases of hypertension and diabetics. No breathlessness, nothing. They were asymptomatic. And 52% of these cases were having heart failure, stage B heart failure. It means they were not symptomatic. Either their GLS was low, LA size was dilated, or their LA volumes were high.
Yeah, exactly.
And
So
that's meant for physicians. The cardiologist will not see all those kind of things. So take home message is good LA evaluation is very important in hypertensive and diabetic subjects as on today.
exactly. I think that's a great point to pick up the stage B heart failure with patients with comorbidities, and echo comes in handy for that. Thank you, Dr. Rakesh. We will now move to the next speaker. Next speaker is Dr. Satish Goin, and he would be showing you cases where the bedside echo had unraveled the mystery.
Uh, Good evening to all of you. Greetings to my fellow panelists. And it's the first weekend after Deepavali, and I think getting back to our routine. So wonderful way to start listening to these great cases and great talks. I will be adding a couple of cases to this. So let me start with the first case. So this is middle-aged female, a healthcare worker, a typical worker who was under a lot of stress in terms of physical and mental, a lot of comorbidities in terms of diabetes and hypothyroid. And because of the work which was doing, it resulted in some physical ailments in terms of headache and body ache. And she went to a clinic, and there she was given IV diclofenac, and she developed an anaphylactic shock. And she was treated for the anaphylaxis, and eventually she was referred because her hypertension was there, and also because of her comorbidities. And she came with symptoms of giddiness, and on examination she was conscious, tachycardic, typical sort of features of shock. And at this point, she underwent an ECG, and the ECG shows her heart rate of close to around 100 and a lot of T inversions, but otherwise unremarkable. And the QTC is sort of borderline, somewhere around 460 milliseconds. And so this was her baseline ECG. And as any triage workup in a cardiac setup, first the ECG, and then we have the blood, and then you have the echo. So we went to the echo. And here in echo, you can see that there's a lot of LV dilatation over there. And at closer look from multiple angles, it started to look as though that it was only the basal segments which were contracting, and the mid and the apical were almost akinetic and seen from all views. So you have the long axis, and then the 4 chamber and the 2 chamber, and the short axis also. And this was at the time of is being seen in the triage. So this was early known. And investigations showed mildly increased markers in terms of troponin and the CPK. And then the sugars and the TSH were mildly increased, not much over there. Dyslipidemia, the creat was good, and then the counts were quite okay. So the management was at this time, because of the shock, she was put on inotropes, and then later on with the echo. So re-looked at the management in terms of the vasopressors, and then continued with the other medications, and also the antiplatelets are also included. And later in the night, the echo was done again as a follow-up as she was shifted to CCU. And you can see that now the chambers are a little less dilated, and the segments are sort of more contractile, so more sort of active LV over there, and starting to look a little promising at this point. So within less than 10 hours, a patient started to show signs of improvement as far as the LV was concerned with the use of echo. And then the GLS at this point showed a GLS of around 8. And then if you look at the mitral inflow Doppler, though the tachycardia is there and the E and A are fused, you can see that the E is more and the A is less, something like a grade 2 or a grade 3 diastolic dysfunction. So at this point, she was further gradually stabilized. And in view of the increased enzymes and then also for the risk factors, and she gave history of previous chest discomfort and also the ECG changes, CAG was considered and the angiogram was done. And the angiogram showed no significant lesions and it was fairly okay. And echo was continued to be sort of looked into, and then 3 days later we can start to see that the echo shows that the LV has improved, and the wall motion abnormality which was there earlier in the mid and the apex has now almost disappeared. It looks almost like a normal LV now, contracting very nicely. And then there was color also, though I've not shown it, so it was quite okay. The valves were quite good, and there was no pericardial effusion. So at this point, diagnosis of stress cardiomyopathy was made, and the trigger was a combined one. So physical stress in terms of the anaphylactic shock, and also the fact that she had been under tremendous physical work at her workplace, and also a lot of mental stress, so because of her financial conditions, a combination of multifactorial. So these are the pre-discharge images and showing a very good LV. And then you can also see that the diastolic function now has come back to grade 1. So this is more of an improvement compared to the grade 2, grade 3 pattern which was seen at the time of when she came in. And the GLS improved very nicely to all its normal GLS here. So she was stable, and then she continued to come back and see us, and she was doing well. Follow. So primarily the focus is on stress cardiomyopathy here and what it is all about. So you can have two triggers. You can have an emotional trigger and a physical trigger. It's more often these days, the focus is on physical triggers. And the risk factors, you have these ones who are sort of prone to it. So you have the females, especially the postmenopause, and then those who have some psychiatric ailments, and then you have the pulmonary causes, and then comorbids like diabetes, and those on chronic medications, substance abuse. And then these lead to changes within the endothelium, and then it causes some microvascular dysfunction. That's how the stress cardiomyopathy happens, and they're more prone to it. But otherwise, you have the catecholamine surge, and then you have the direct cardioinhibitory effects, and this is how it hits the LV and then causes that. So, and ECG in stress cardiomyopathies, typically they are sort of minor changes, and almost 95% of them show some sort of changes, and T-wave inversions are more. And you do have an ST elevation sort of somewhere, not much, but you can get ST elevation also. QT can be prolonged, as in our case, it was almost around 460, and ST depression is much less, and then you can have LBBB also. And then the types of stress cardiomyopathies can be the classic ones, which we are all well aware of, the apical ballooning syndrome, where we have the mid and apex. But also to a lesser extent, about 20%, 10 to 20%, you can have mid-ventricular. So it's more of a circumferential extent where you have the mid segments which are involved. And then in the younger patients, more often, especially patients with hanging and other sort of triggers, physical triggers, you see more of the inverted type where you have the basal segments which are hypokinetic, akinetic, and the mid and apex are relatively spare. And then you have the biventricular, which is really bad. So these patients come in a real sort of bad shape, and then they can come with arrhythmias and they don't do well. So where the RV is also involved. And then you have these focal dysfunctions where I think it is more of underdiagnosis and not really looked into, but they're also there. The rarity is maybe because of underdiagnosis. And then you have a lot of these criterias. You have the Mayo Clinic, and then the European Society, and then you have the registry of the Takotsubo. So that also is a new one with a lot of numbers. So the key thing common to all is that you have the RWMA, which is not territorial, and then you have the ECG, which shows some changes, but minor changes, and then you have the trigger, the background, which is there in terms of some emotional or physical trigger, which is there. And then, of course, the key to it is to get an angio done, and that's sort of rules out. And then you also have BNP also to some extent, which can be helpful. So in our case, we use another registry called as Intertac, and then we did a scoring. So you can see that the scoring, there's a probability of almost more than 80% over here. And then just a brief look at even how medicines also can cause the stress cardiomyopathies. So here you have antibiotic induced, and then you have unintentional injection of large doses of epinephrine. And then you can have contrast also can cause stress cardiomyopathies. And a case of even bee sting. So this is just to bring awareness of stress cardiomyopathies can be caused by a wide variety. And how we can look at is we can look at the ECG, initially symptoms, and then comes the ECG, and then afterwards we go through the sequence of looking at the biochemical parameters, a lot of ruling in and ruling out. And echo plays a key role, especially when it comes in a very classical way of the wall motion, providing the mid and the apical non-territorial involvement. So that is where the echo sort of really plays a key role, and also follow-up of the echo when it shows that it is recovering, sort of almost clinches the diagnosis of stress cardiomyopathy. And you have these differentials, so one has to keep in mind. And of course, the myocardial infarction is the key to the whole thing. So we should not, we should be very aware of myocardial infarction. So apart from myocardial infarction, so any other wall motion in terms of where it causes wall motion is myocarditis also. So these are the two other differentials which we have to keep in mind. And then we have these various ways of looking into it in terms of biomarkers and the multimodality imaging also. So the take-home message is not all wall motion abnormalities need to be coronary artery disease, and stress cardiomyopathy is seen more often than what we actually think it is, and especially should be more aware in males, and in the hospital setup, it can be a physical trigger and more often seen in the intensive care echo, and these are the secondary types, and these people don't do well, and serial echoes are crucial to establishing diagnosis. So this is my first case. I'll go to the second case, and then we can take the questions. So the second case is of an elderly lady, and comorbids again in terms of hypertension and diabetes, and then resulting in chronic kidney disease. And then she was undergoing dialysis, and then she came for dialysis, and then she had a AV fistula also done. And at the time of just before she started to sort of being planned for dialysis, she went into left ventricular failure, and that is when things started to go in a different direction. So these are images initially at the time of admission before she became unstable. So the echo looks fairly good. So nothing in terms of any major abnormalities, normal chamber sizes, a little bit of LVH, valves are good, not much of valve lesions, and then you have a mild LV diastolic dysfunction. So, and then the PA pressure also is within acceptable limits. So, so when she went into LVF, so she collapsed, and she had a team which came and did a CPR. And with the aid of this CPR team, they were able to revive her. And then she went through the usual workup post CPR, and the ECG was okay, nothing in terms of the labs. And she gradually improved, and then she underwent dialysis, and then a repeat echo was done as a routine in terms of her event, and also the dialysis which was done. And then this is where things got a little interesting. So now you see that there was no effusion earlier, but now we start to see a little bit of pericardial effusion. And then the LV size appears to be the same. Function also is good, so no problems there. And then what sort of really got our attention was that there was a small saccular sort of outpoaching at the RV apex, which was not there earlier. And then looking at it more closely, there was small communication between the RV cavity and the outpoaching. So nothing much inside the RV cavities. There was no clot or any other material inside the RV cavity. And on putting color, you can see that there's a bit of a color flow over there, indicating that there is a communication between the RV and the outpoaching, suggesting that it is a pseudoaneurysm which is developed post CPR. And again, looking at it closely, putting the Doppler, you can see it being established. And the subcostal also gives a fairly more comprehensive picture where it is located and how the pericardium also adjacent to the RVAs also can be clearly seen. So good subcostal enabled us to get some good imaging here and able to identify the outpoaching, the pseudoaneurysm over there. Not great CT images. So this again, because post event, she had an arterial line and then she developed a pseudoaneurysm. So CT was done both for to look at the primarily to look at the pseudoaneurysm. And during that time, they also picked up the outpoaching which was there on the RV also. So confirming what we had already seen. So they also concluded that it was something similar to a pseudoaneurysm. And this was secondary to the CPR. A surgical opinion was taken, and then in view of her comorbids and advanced sort of health condition, patients and relatives were not keen on any intervention, and then she was discharged in stable condition. And surprisingly, she came back a month later, continued to be sort of stable. And these are the echoes, again, sort of showing that nothing much has happened over the intervening period. But on closer sort of imaging of the subcostal, you can see that there's a little bit of a, I would say a little more than that, an organized hematoma which has formed. So gradual leak, and I think it had probably sealed up and sort of ensured that the pseudoaneurysm was sort of stabilized and there was no further advancement. So this was what was there after 1 month, and she continued to be sort of doing well. So just a brief look at the literature, and rupture of the right ventricle due to CPR can happen. And so these are anecdotal sort of reports. So what sort of really has to be kept in mind is that when a CPR is done, it can cause rupture of the chambers, it can cause rupture of the coronary artery, aorta, and this can result in pericardial effusion, tamponade. So these are post-CPR, so nothing related to the index event. And those with small body hepatitis are more prone, and those with cardiomegaly are more prone. And in patients with pulmonary thromboembolism with PH, they're also more prone. Apart from the cardiac complications, one has to keep in mind during CPR, you can have sternal and rib fractures, and then you have lung problems in terms of hemopneumothorax, and also bad CPRs or very aggressive CPRs, misdirected CPRs can also cause laceration of abdominal organs. And just a bit of message, especially when it comes to the RV. So when it's a high pressure RV in terms of pulmonary hypertension, so these are patients who are susceptible, and this is typically at the RV apex where you have the stress which is there between the apex and the mid, which causes the myocardium to be vulnerable. And manual compressions are sort of comparatively much safer. They have done also studies where they compared manual versus automated, and they found that the automated were more aggressive in terms of its compression. So where manual, you were able to control the compression, so less sort of injury. And chest compressions can cause, or it can already, if there's a rupture or a cardiac condition which is there, it can also worsen. So it can happen in different ways. So this is just to highlight the hazards of CPR and what can happen, and how echo can be helpful in terms of identifying complications, especially cardiac complications. So it is also vital that echo to be utilized post CPR when the patient is revived, to look at it a little more carefully, and also serial echoes can be helpful in identifying how the lesion is doing and how the patient is doing. Thank you.
Thank you, Dr. Satish, for bringing out those two important points. One was obviously the stress cardiomyopathy. which actually, because of the increasing awareness, more and more ICUs are finding those cases. So let me tell you that almost 20 years back, it was highly questioned whether, the stress cardiomyopathy exists or not. And now it has become a very important established diagnosis in the critical care setting also, and even in the regular setting also, with the patient coming with acute heart failure. So Sati, I just wanted to ask you a few questions that you had beautifully shown that the stress cardiomyopathy can have a really different kinds of regional wall motion abnormalities. Okay, so one of those, like only the basal having akinesia, or some of them only the equatorial having akinesia, or only some regional wall. Sometimes they are non-coronary territory, so it is very easy to make out, like your apex is only contracting and rest is not contracting. You really know it. But in our classical Takotsubo, when it is only apical ballooning, sometimes it becomes very difficult to differentiate it from an interval MI. So, are there any echo clues by which we can differentiate, apart from the patient's clinical profile, that this looks more like a apical ballooning syndrome or the Takotsubo rather than the interval MI?
Okay, so if you're looking at, so for example, for a STEMI, so if it is going at LAD especially, so definitely you're going to see a lot of ST elevation. ECG changes are going to be very crucial to look at it. So it will be more marked and more obvious. That is number one. And secondly, looking at the enzymes, so you'll have a very high enzymes, again, depending on what is the extent of the lesion and the proximity of the lesion. So the enzymes are also very important to look at. In Takotsubo, you see moderate or even less, or sometimes even it may not be there also, borderline. So that is another point. And one can, beyond that, is to the echo sort of really sort of looking at the territorial part of it. So typically, if you have an LAD sort of lesion, you will get to see the wall motion in that LAD territory. So if you look at the apical ballooning, you will see it's a non-coronary sort of territorial distribution. So that also sort of helps you. And I think the last part of it, very crucial, is that even if there is the suspicion of the Takotsubo is still there, it is a serial echo which helps you. And over a period of a week or 10 days, you will see this wall motion sort of gradually going away. And it most of the time, it sort of comes back to normal. So that sort of really helps in trying to differentiate at a low setting where you can sort of, make your own diagnosis. At a higher advanced setting, I mean, definitely looking at, you can, if you have the option, if you have the luxury of asking for a cardiac CT, looking at a CT coronary angiogram, so that can be done to look for any coronary problems, or you can go the full sort of approach and do a coronary angiogram, a full-fledged coronary angiogram. So you have these two settings, and that's how we can differentiate.
Yeah. Secondly, two other complications. Can you elaborate the possibility of developing a clot or developing a dynamic LVOTO in a Takotsubo?
Oh, yes, I think great points. So definitely, one is when there is extensive wall motion, as you saw in our patient, where the LV balloons, and then you have a very akinetic apex, especially the apex, which is very vulnerable. So suddenly the flow starts to stagnate, and you have a low output over there, and that is where clots can form. And so there should be a high degree of suspicion, and all efforts of those who are doing echoes should be there to make sure that you use your knobs and use whatever the knowledge you have to look at any sort of presence of any thrombus. And again, if you have an alternative, you can use contrast also. So as to rule out just pushing in myocardial contrast, you can identify whether the clot is there or not. And there have been a lot of reports about these people embolizing from this. So very important that you be aware of the presence of thrombus over there. So that is one side of it. The second side is that those who have small LVs and those who have especially a very dynamic basal segment contraction. So what will happen is it brings the LVOT very close to the mitral valve, and you have the mitral valve sort of coming in the way, and it will start to obstruct the flow through the LVOT, and then they can have a dynamic obstruction. So you can have a gradient which is there, and also there'll be associated MR. So in these patients, management suddenly totally shifts, and you're not supposed to give inotropes here. And it is mainly a question of trying to sort of be very conservative and be very careful, and probably a bit of fluid management can help, and maybe a little bit of slowing down the heart rate also might help. So that is about the side where you can have an LVOT. But when you have a patient like ours, where these patients can sometimes come in pure frank heart failure also. So then you have these very other extremes where they can be sort of coming in cardiogenic shock, and then you have to sort of run through the usual. You sort of try and differentiate what the cardiogenic shock is. It a left ventricular type, or is it a low output type? And based on that, you sort of go for vasopressors, and then inotropes. You have to be very careful. And then you look at the ARBs later on, and then the beta blockers. So these are sort of medications like a protocol. In an extreme situation in a cardiac setup where they go into absolute shock, and one can look at mechanical devices in terms of ECMO, or you can one has to think of it. So if you do have a patient who's not responding well, so please do look at an alternative. These patients may benefit if you send them to the cardiac hospital, where they have the option of putting in assist devices, and even an ECMO where they can come out of it and it can be helpful. So that is the other side. And then as a corollary to what you already said, just a few examples. Younger patients sometimes they come with hanging, especially suicide attempts. You can have reverse cardiomyopathy, where you have the sparing of the mid and apex, but they will have a basal segment hypokinesis. So do consider possibility of stress cardiomyopathy in such patients. And the patients with cancer, they can come with RV involvement also. And those with RV involvement, you will have a lot of problems, because they can have a lot of arrhythmias, prolonged stay. And these are the patients whom can, actually there will be mortality also. So typically, I think in a clinical way, any stress cardiomyopathy, if they recover within the first 10 days, they are the ones who will do well over a longer period of time. If the recovery is prolonged beyond 10 days based on data which is out there, so that they take a longer time for the wall motion abnormalities to come back, the BP to be stabilized, and heart failure to be stabilized, over a period of 4 to 5 years, they don't do well. So more number of people have a higher mortality and a morbidity. So you can look at their recovery also, in terms of how fast they recover and how slow they recover. So that also can guide you to look at your own patients and follow them.
Yeah, correct. I think that brings out that very important point why we should have a serial echo in Takatsubo, because you can pick up these clots, you can pick up this dynamic LVOTO in a patient who is not improving, and there definitely will not use an IABP. In that case, your ECMO would be a better choice. So that is how the echo is so vital in this stress cardiomyopathy, to do it serially, not just at time zero to diagnose, but also you should do it almost daily, or at least alternate day. I think that was a very important point brought out by this discussion. And lastly, your second case was a very exotic case, but that brings to this question of the blunt chest trauma causing problems to the heart. So can you just tell, in a blunt chest trauma, what are the things to be looked on the echo for the possibility of injury to various cardiac structure, or the commonest structures that get involved by the blunt chest trauma?
Okay, I would sort of I agree that trauma is important one. So I would like to highlight aggressive CPR can also result in these sort of trauma to the chest. So it starts from the chest wall itself. So chest with rib fractures are pretty common. Sternal fractures are commonly seen. So it is okay. But when it starts to go in and puncture the lung, and those are sort of less likely compared to the rib fractures, but they can still happen. So you can have a resuscitation which has been successful. You've been able to revive, but you will still have a patient not doing well. And that is when you have to consider that possibility that CPR has caused this. So that was one of the reasons why I wanted to highlight how the CPR itself, how it can lead to problems. Though you can revive the patient, but you can cause a secondary problem, and that itself needs to be tackled. So one is to definitely look at lung traumas, rib traumas, and more aggressive ones, especially in patients with frail, thin people, cardiomegalies, and then aggressive, again, compressions. So you can have a trauma to the chest, and then you can have the damage to the pericardium. So that can cause hematoma, that can cause tamponade. So tamponade can be a problem, secondary to the CPR itself. And this is where echo can be helpful. So do consider echo in a CPR patient who's not doing well. You have revived the patient, so you can put just a probe and see what the problem is. And if you don't see an effusion, or if you see an effusion, start thinking that maybe the CPR has caused a trauma. And then, of course, a patient who did not have any earlier valve problems, maybe sometimes aggressive compressions can cause papillary muscle sort of injury, and you can have an MR which is not there suddenly, which is appearing there, or a wall motion which was not there because the coronary artery got torn. So these are less likely, but they can always be there. But awareness, if it is there, can help you to sort of manage, and your the thought process and your management sort of improves. So
Even a
these are.
tricuspid leaflet, yeah, a tricuspid.
Nitin, can I put 2 points?
Yes, sir,
Yeah,
definitely.
number one, although we call it a stress cardiomyopathy, should be restricted only to apical ballooning or Takotsubo, because there are some cases which have been reported under the heading of happy heart syndrome. They've written a happy heart syndrome and of these things also.
Yeah.
So should we still retain the
So
terminology stress
I will
cardiomyopathy?
answer that question.
Second,
So
second point was
yeah,
that,
uh,
1 minute. Second point was that I have two cases with me who had following their chest trauma. They had a tricuspid valve completely avulsed and complete rupture of the papillary muscle with a severe TR. But they were still asymptomatic because their pulmonary pressure was normal. So I think because of their anterior location, the right ventricle and the tricuspid valve are more commonly involved in a chest trauma rather than the other structures also. So these are just two observations.
yes, I will.
Now you can come to happy heart.
I will make a point. So it is a question of emotional trigger. So usually the emotional triggers are more often negative triggers, but you can also
Yeah.
have positive trigger. So that is very much there. So it is just a catecholamine surge. So you can have a sudden acceleration for whatever reason. That also can cause the so-called happy heart syndrome, but still it causes problems in a different way. So that also has been shown to happen.
Actually, the
Yeah.
mechanism is the same. Like you are, from you have got the brain and heart crosstalk, and which is actually a very heavy crosstalk. That's why the heart suffers, whether it is extreme happiness or extreme sadness. I thank Dr. Satish Goin for that, for those two excellent cases. And now we'll move on to the next speaker. Next speaker is Dr. Shanmuga Sundaram, the past president of Indian Academy of Echocardiography. He will be showing you the bedside echo cases in the critical care scenario. Dr. Shanmugasundar.
Good evening, dear colleagues. From the presentations we had already, we are sure that echo has a pivotal role in establishing the etiology of many cardiovascular emergencies that present with the following cardinal symptoms, namely dyspnea, chest pain, palpitation or syncope, hypotension or shock. My patient is an elderly female who came with dyspnea, and the diagnosis was delayed despite being aware of the cause. 74-year-old female with diabetes, hypertension, and hypothyroidism came with history of effort dyspnea class 2 to 3 for 2 months, which rapidly progressed to class 4. She was orthopneic in the last 1 week. She was unable to lie flat and preferred to lie on one side or get propped up with the 3 pillows. She also noticed edema legs for the last 2 weeks. She was admitted elsewhere. She required BiPAP to maintain oxygen saturation. Got transferred to a place. The past history, the only significant feature was the presence of low-grade fever with cough lasting for a few days prior to onset of this problem. There were no other cardiac complaints, no history suggestive of sleep apnea, COPD, or causative factors for pulmonary embolism. She had the hysterectomy 40 years ago. Physical examination in the emergency room revealed a tachypneic sick individual, a prominent accessory respiratory muscles, SpO2 at room air was 88. She required BiPAP to maintain the oxygen saturation. Pulse rate 96, blood pressure 170 by 88. Jugular venous pressure was normal, heart sounds normal, no murmur. Basal crepitations were there present, and there were few scattered wheezing sounds are also there. ABG was done quickly at the bedside, which revealed type 2 respiratory failure, mild one, PO2 of 54, PCO2 of 54. Initial diagnosis was acute heart failure, plus or minus sleep apnea. Because of the history of orthopnea, high blood pressure on admission, basal crepitations, and H2F PEF score of 5. She was started on intravenous diuretics and valsartan with an antibiotic intravenously. This is the electrocardiogram, did not contribute anything. An echocardiogram was done at the bedside, revealed hypercontractile LV. Right ventricle was also normal. There was mitral annulus calcification causing mild degree of transmitral obstruction. Tricuspid regurgitation was trivial. An incomplete TR signal. We could assess the right ventricular systolic pressure to be around 50 millimeter of mercury. IVC was not dilated. She was moved to CCU for further care. Blood count, biochemical investigations were normal. Bro BPNP was just 161. Troponin was normal. Because of normal pro-BNP, absent B lines in the lung ultrasound, absence of interstitial edema in the plain CT, and type 2 respiratory failure, I revised the diagnosis that it could be of lung pathology. Pulmonologist was called in. He said, it could be acute exacerbation of COPD. She was put on, BiPAP versus Venturi mask. Alternatively, IV cefeprazone, nebulizers, chest physio, and even IV methylprednisolone. Waited for 2 days, 3 days. She didn't make much of an improvement. ABG remained almost the same. PCO 248 and PO2 at room air was 63V. This is the plain CT which was done before moving her to the CCU. Revealed some, plate atelectasis in the posterobasal segments. And a contrast CT was done 2 days later because she didn't make an improvement. We want to rule out small, pulmonary, multiple pulmonary emboli into the segmental vasculature, but it did not reveal any thrombus in the pulmonary circulation. Then, suddenly, I thought I should check her diaphragm movement. Both the diaphragms were static. This is a subcostal view. This is the diaphragm and this is the liver. And the left side, we could see the spleen and the left dome of the diaphragm. With the breathing, the diaphragm on either side did not move well. I had a similar patient, but not in the inpatient side, on an outpatient side, where I could, make out bilateral diaphragmatic paralysis. This is the second one I'm seeing after, in the last 40 years, this is the second one. Took her to the cath lab, confirmed that the diaphragm was not moving in the fluoroscopy on either side. And I connected it to, BiPAP. Because of the positive pressure, lung was expanding and it pushed the diaphragm, and the diaphragm was showing movement. It is a passive movement because of positive pressure expanding the lung. So the diagnosis was confirmed to be bilateral diaphragmatic paralysis. Worked out possible causes for diaphragmatic palsy. Investigations for myasthenia were negative. Screening tests for connective tissue disorders were negative. Nerve conduction studies revealed chronic demyelinating polyneuropathy. Repetitive nerve stimulation was negative. Presuming that it could be post-viral, neuropathy causing bilateral diaphragmatic paralysis, she received IV immunoglobulin, continued steroids. She was with us for another 3 days and she got shifted to a native place. Apparently, she still requires BiPAP at nights when she lies down, and managing the daytime with the intermittent oxygen and sitting posture. If you look at the causes of diaphragmatic palsy, it could be unilateral or bilateral. Unilateral is generally asymptomatic or may produce mild symptoms. Bilateral diaphragmatic paralysis generally produces marked symptoms in the form of dyspnea and orthopnea. There are multiple causes, anything which injures the phrenic nerve on either side, or any neuromuscular problem affecting the diaphragmatic muscle. starting from trauma, malignancy, infections, inflammatory conditions, neurological disorders, muscular disorders like muscular dystrophy, neuromuscular causes, and even sepsis can result in transient paralysis of the diaphragm on either side. And lastly, idiopathic. The diagnosis, one can definitely suspect on the clinical grounds if you could see someone who develops profound dyspnea when they lie down with the desaturation. And the most important sign is the paradoxical movement of the abdominal wall. When the patient takes an inspiration, the diaphragm moves down, the chest wall expands, and the abdomen also moves anteriorly. In contrast, in people with bilateral diaphragmatic paralysis, the abdominal wall, abdominal musculature contract and move in rather than moving out in line with the chest wall. So this is a very classical finding. And, because of inadequate oxygenation, hypoxia, hypercarbia, which may lead to pulmonary hypertension and right heart failure. ABG, classically hypoxia with hypercarbia, respiratory acidosis may be present. Chest X-ray may show elevated diaphragm, but very, easily diagnosed if it's unilateral because you could see the difference between the two sides. But bilateral diaphragmatic palsy can get missed out because people may think that it is a poor inspiratory effort which is causing for the highly placed diaphragm. But fluoroscopy definitely confirms, echo definitely confirms. CT chest is again, static image. It may miss the diagnosis. You can do a lung function test in, sitting and lying posture. If the forced vital capacity comes down dramatically with supine posture, you can suspect this. Ultrasound features are described. The thickness of the diaphragm may be less. The inspiratory descent may be less. The diaphragmatic muscle may fail to thicken during inspiration. These are all the signs. You can put a balloon and measure the pressure in the esophagus and the stomach. Demonstrate a transdiaphragmatic pressure gradient being lesser than 40 centimeter of water. And you have EMG and phrenic nerve conduction studies to confirm the diagnosis. Treatment, unilateral diaphragmatic palsy, generally no requirement, no treatment is required. Bilateral treatment of the cause, if they don't improve, they may require BiPAP forever. Some may need tracheostomy and mechanical ventilation forever. And we have, units which can be implanted in the abdomen, which can do the electrical stimulation of the diaphragm. The first patient which I saw came to outpatient department with dyspnea and orthopnea. When I made him lie down in the couch for an abdominal examination, I could make out that the abdomen was caving in during inspiration. He was profoundly orthopneic. Saturation dropped, very drastically. This is in contrast to orthopnea, which we see in people with heart failure. So yeah, whenever abdominal wall moves paradoxically, think of diaphragmatic palsy. I'll come to my second case. It's diabetic and hypertensive, age 64, male, came with effort-induced angina. Angiography revealed significant bifurcation disease of medial AD. Bifurcation stenting was done, drug-eluting stents on 1st of August, and discharged on day 3, came back 2 weeks later with chest pain, fever, and dyspnea. This is the echocardiogram which was done in the emergency room. Presence of pericardial effusion. Not much, but mild to moderate pericardial effusion. But what was striking was the chamber collapse. If you look at the right ventricle, it is caving in. And similarly, you can see the left atrial wall collapse, which is an unusual finding in cardiac tamponade. And you look at the basal left ventricular posterior wall, that was also showing a diastolic collapse. So generally, the wall collapse occurs on the right heart because right heart chamber pressures are normal, are lower than the left heart, chambers. Wall thickness is also lesser when compared to the left heart. But in this patient who has mild effusion, but at the same time, having features of tamponade, this confirms the concept that it is not just the fluid volume alone that is important. It is also the rapidity with which fluid accumulates that also can increase the pericardial pressure, causing cardiac compression. Short axis view, the same findings, RV outflow tract. diastolic collapse. Look at the posterior wall of the LV, a segment of it showing, inversion. And apical four-chamber view, look at the right atrial wall collapse, and left atrium also showing collapse in diastole. This is apical four-chamber view, little magnified, just to demonstrate the concavity of right atrial wall. This occurs generally in late diastole and early systole, in contrast to right ventricular collapse, which occurs in early diastole. IVC was plethoric. M-mode, just to document the temporal sequence of RV collapse. This is systolic movement, and the beaking is occurring at the early diastole in the isovolemic relaxation period. And in addition to it, he also manifested premature pulmonary valve opening. This is the M mode of pulmonary valve. This is during the atrial contraction. This is during the ventricular systole, and this is during diastole. Normally, the valve opens after few milliseconds after the QRS. Here you can see the pulmonary valve trying to open well before the QRS. This is premature pulmonary valve opening, which tells you that the right ventricular end diastolic pressure is elevated. If you look at the transmitral Doppler pattern, it shows the typical flow paradoxes, that is marked swings of the E velocity during respiratory phases. During inspiration, the mitral velocity will come down, and on contrast, in the right side, the tricuspid velocities will markedly increase during inspiration. This is a sign of ventricular interdependence, because the fluid is under pressure surrounding the heart. So whenever an inspiration allows more venous return into the right heart, the right heart gets filled at the expense of left ventricle. So you get contradictory flow pattern. During inspiration, the tricuspid velocities will increase and the mitral velocities will decrease. This is known as flow paradoxes. And this is something equivalent to the pulses paradoxes, which you elicit at the bedside. During inspiration, the aortic velocity come down markedly. Subtle reduction may be there in normal individuals. As you know very well, in the clinical sign of pulses paradoxes, it is an exaggeration of the normal phenomenon. Something like this occurs in the Doppler pattern as well. In addition to the classical signs of tamponade, you also manifested early diastolic reversal of flow in the hepatic vein, which occurs generally in constrictive pericarditis. The tissue Doppler did not reveal any big abnormality. So the diagnosis made was post-cardiac injury syndrome, Dressler's syndrome, which is very uncommon these days. She received 2 weeks of colchicine and oral prednisolone, and he showed complete resolution of the pericardial findings. The common causes of post-cardiac injury syndrome is myocardial infarction and cardiac surgery. But the trauma, accidental trauma as well as iatrogenic trauma, can induce that. There are anecdotal reports of pericardial effusion causing tamponade, effusive constrictive pericarditis or constrictive pericarditis following a pacemaker implantation, following coronary interventions, following electrophysiological studies with radiofrequency ablation. What happens is the injured heart muscle releases the cardiac antigens. It elicits autoimmune phenomenon. This autoimmune phenomenon results in pericarditis, pleuritis, and pulmonary infiltrates. Generally, they have elevated ESR and CRP. And this is after the course of steroids and the colchicine. IVC plethora is no longer present. Premature pulmonary valve opening is present, but the flow paradoxes virtually disappear. The unusual features in this patient was minimal effusion with tamponade because of the rapidity of fluid accumulation. The second one is collapse of all 4 chamber walls. This is quite unusual. Generally, it is the right atrium and the right ventricle that collapse, but we could demonstrate all the 4 walls, showing collapse. Then the occurrence of pericardial effusion after PCA as a manifestation of Dressler syndrome is quite uncommon. Around the same period, I had another lady which had manifested similar phenomenon. Generally, PCA-related pericarditis or FEC constrictive pericarditis generally occurs after coronary artery perforation. Even in this patient, though the angiography did not reveal any complication, there is a possibility that microperforation induced by wires could be the cause, or myocardial injury that occurred because of balloon dilatation, repeated balloon dilatation could be responsible for the pericardial pathology. And the fourth interesting feature which was present in this case was the concomitant presence of both findings of tamponade as well as constriction, called as effusive constrictive pericarditis. I'll just stop with that and wait for the discussions. Thank you.
Thank you, Dr. Shanmugasundaram, for those two excellent cases. I think the first case where the breathlessness was evaluated, the dyspnea was unexplained dyspnea was evaluated by echocardiography, actually shows the power of echocardiography, that how it can unravel the mechanism of breathlessness. So it's like, in Mayo Clinic, they have a dyspnea clinic. I think that kind of a thing, because and a lot of things are evaluated by doing a stress echo with a CPAT and so on and so forth. So echo is such an important modality to unravel the mechanism of dyspnea, and it was very well shown by looking at the movement of the movement of both the diaphragms. And that brings me to important thing that I always teach my fellows, that if the post CABG patient, okay, where many times the after sternal opening, many times the phrenic injury occurs, okay, if the patient is not coming out of the ventilator, look at the diaphragms, okay. Many times you will find that there is actually a diaphragmatic paralysis, and that is the cause of his not coming out of the ventilator. And that also brings me to this important point, that in echo we are now also started looking at the lungs, okay. So I would like you to elaborate on what important informations we get by just moving the probe to the lung.
I mean, the last few years, I've been asking my echo technician to, look at B lines. In anyone who comes with dyspnea, don't just stop with imaging of the heart. Go to the lung and look for B lines. That has helped a number of occasions. Now, after my second encounter of bilateral diaphragmatic paralysis, I have asked my technician to include it as one of the findings to be reported in the echo report, diaphragmatic movement on either side is normal. So to that extent, I think, you should look for interstitial edema, which appears in the form of B lines, or the diaphragmatic movement. And these are the other things which we need to look at.
Exactly. So that means
Well,
you are just see, because you are not doing anything extra. You are just spending another half a minute just to move your probe to left and right lung, and we get such a rich information, because those B lines that we see is a definite evidence of an interstitial edema. So either it would be because of heart failure, or even an active interstitial lung disease also you can get it. But that gives you an important clue about how well the patient is diuresed or not diuresed, and the mechanism of dyspnea. And also now looking at the diaphragmatic movement, and obviously the pericardial effusions will stare at you by looking at it, and also you will know that you are not diuresed the patient well before discharging the patient. So it is so echo is such an important tool even for those acutely decompensated heart failure patients before discharging them, by looking for both these B lines, and also for the pleural effusions, and obviously for the IVC. I think that is a very important point that you brought it from your case. Now the second case was obviously
well,
the
doctor.
fusion pericardial. Yes, sir. You wanted to add something, Dr. Parashar? You
No,
wanted to
no,
add?
please carry on first. Then you might be covering the same point. You can carry on, please. Carry on.
Yeah. So
I
the
mean, what I meant, I
yes,
may be right or wrong, but because we are dealing with physicians,
yeah,
I feel that all cases of pericarditis should be treated with colchicine
yes.
because the development of a recurrent pericarditis. So I will require your views that rather than doing all the things that should colchicine be given to all cases of pericarditis?
Yes, Dr. Shanmugh Sundaram. Dr. Parashar is asking whether you would prefer using colchicine in all your patients of pericarditis.
My preference is that because this patient after PCI is already on aspirin, not the anti-inflammatory dose, but at 75 milligram a day. If you look at the response of pericardial inflammation to drugs, I think colchicine stands as number one. Reason being, if you exhibit steroids first, the relapses are supposed to be more common. But that doesn't occur with, or occurs less common with colchicine. So invariably, my first choice is colchicine, even in the first encounter, particularly when I had seen someone after the procedure where I suspect restless syndrome and the combination of both, tamponade and constriction made me to think that it is an immense inflammation going on. So I would like to use anti-inflammatory therapy. So I have actually started on both drugs together.
Yeah, because the incidence of recurrent pericarditis is almost about 30% in those
Yes.
who are not using colchicine. So I think it should be because we are dealing with physicians. So I think colchicine is a good drug for them now.
Yeah,
Thank you for your excellent presentation of the cases.
and I think the second case of Dr. Shanmugasundaram actually
Yeah.
highlights a very important point of doing an echo in a patient with a complex PCI. Now, this was a bifurcation PCI of a very proximal LED diagonal lesion. So it's a complex PCI, definitely. It's very important because many interventional cardiologists forget about the echo post procedure. But I always tell my patients to at least look them at 24 hours and pre-discharge by echo, because many of these, as you had rightly shown, that some of them, because of say small wire perforations or repeated balloon inflation, you may have some leak somewhere. Okay, and that can actually make the patient, the patients are on dual antiplatelets, and these patients can suddenly worsen because of a pericardial effusion, rapidly accumulating pericardial effusion. So I think all complex. Then secondly, as you said, that there was on the post PCI angio, there was no leak, still he developed it, and the dressless was the possibility, and it is very much likely because in complex PCIs with reperfusion injury and also multiple small peripheral embolisms into those coronary circuits can cause small infarcts, and that has been shown on cardiac MRI as small LG lesions after complex PCI. So that could be like peri-procedural infarct causing dressless. That can also be very likely. And another remote shot, obviously not in your kind of institutes, but in very small peripheral institutes where there is a reusability of the hardware. Some patients after 2 to 3 weeks can come with pericardial effusion, and that could be a stent infection. And those cases had also been seen, especially coming from the small centers where there is a tremendous, resource restriction. The reusability has caused the infection. I think lastly, I will ask Dr. Shanmugam one question, because he had been a professor and he has seen the growth of cardiology. Do you think that the point of care ultrasound is going to replace the stethoscopy or our regular clinical examination?
I don't think so. The clinical examination, the limitations are there. We realize the limitations more and more when we use, particularly the echocardiography imaging. We realize the limitations, but nothing like elicitation of history, and nothing like spending half a minute on clinical examination. Not 5 minutes, 10 minutes. Half a minute is sufficient for an experienced clinician. It should be
Well,
there. It should
if
be
you
there.
see my first slide which I presented, I wrote clinical information, 2D echo and Doppler. But unfortunately, the thing is that patients are referred for echo without even doing a clinical examination. As you have rightly pointed out that I have I have one case I don't want to present that lady was being treated for a as dilated cardiomyopathy for many years because of LV enlargement also. When she came to us, by mistake we put a stethoscope, and then we found that it is a case of PDA. So
Okay.
from a non-treatable condition, she became a treatable condition. So the disadvantage of a echo is that it has lost the relevance of a clinical examination. That is one thing. But I
True.
think that is still the we must do a good clinical examination. I agree with you. Yeah.
So exactly. So that means the clinical examination is obviously a bedrock, and this point of care ultrasound is an extension of clinical examination, adding a very rich data to our examination findings. So I think both should happen one after the other. And lastly, again, Dr. Shanmugasan, I want to ask you another question: is that we have discussed all this point of care ultrasound in this particular series. So, do you think that you need a different kind of training for focus and different kind of training for a full formal comprehensive echo? Because why I'm asking this question is because there is very likely that the point of care ultrasound may be done by the anesthetist, by the intensivist, by the emergency physicians. So, and obviously the MD physicians in their nursing homes. So, do you think that we should have a different curriculum for focus versus different curriculum for the more comprehensive formal echo?
I think everyone should have at least short course on comprehensive echocardiography, like what to look for, what is the way of looking at the different windows, what are the structures seen. That aspect should be known to them. Then subsequently, like major conditions like large effusion, dissection, valvular regurgitations, LV dysfunction, pericardial effusion, tamponade. Most of the things now my emergency room residents are making out. They don't have a sophisticated unit there. They have a 2D, which can also give some color Doppler and pulse Doppler, but a very old system. But they are able to make diagnosis. They went through a formal training in our echocardiography unit.
Thank you. So I think we had a very fruitful discussion about the power of echocardiography for the critically ill patient by doing the bedside echocardiography, and all the cases were exemplary of that. And we made a very important point. All the four speakers had shown very important and cases, and very succinctly bringing out the point, and how the echo has helped in getting the diagnosis and saving the patient's life. So I give my heartfelt thanks to all the speakers for the wonderful job, and I will hand over the podium to the Glenmark team.
Thank you, sir. Thank you so much for moderating the CME, and thank you all to all the speakers for your very insightful case presentation. Now, as we conclude today's session, I extend our sincere gratitude to all our esteemed speakers for their insightful presentation and generous sharing of expertise. A special thanks to Dr. Nitin Barkale, sir, for his thoughtful moderation, and all the eminent speakers for their partnership in advancing the cardiac education. To all the participants, thank you for your engagement and commitment to clinical excellence. We look forward to welcome you all to our next webinar. Until then, stay inspired and keep echoing excellence. Thank you.
Thank you. Thank you.
Bye-bye. Good night.
Good night, sir. Thank you.
Yes, with the permission, we'll end the meeting. Thank you.
Yes.